Hello, everyone. My name's Rachel Morton. I'm a Professor of Health Economics at the NHMRC Clinical Trial Centre at the University of Sydney. And on behalf of my co-convener, Richard Norman, and we welcome you to the ACTA HEAT Special Interest Group seminar. This is a seminar or a webinar every 2 months that's been coordinated by the fantastic staff at ACTA. I'd like to acknowledge traditional owners of country. So for me, I'm based in Camperdown today, dialing in from the lands of the Gadigal people of the Eora Nation. And I'd like to pay my respects to elders past and present and any First Nations people that are with us today. The webinar series, as I mentioned, is a 2-monthly series. And just to let everybody know that the April webinar, the topic is optimal quality of life data collection and analysis alongside randomised trials. Our speaker today is probably known to many people. He's a professor at the University of York in England, a professor at the Centre for Health Economics and co-director of the Equity and Health Policy, or EquiPol, research group. He's helped pioneer equity-informative methods of policy analysis, including distributional cost-effectiveness analysis, health equity indicators for health quality assurance, and methods for investigating public concern for reducing health inequality. Professor Richard Cookson is an honorary public health academic, and he's been on a number of advisory committees for the NHS and for NICE. He holds a BA in Politics, Philosophy and Economics and a DPhil in Economics from the University of York and an MPhil in Economics from the University of Oxford. We're delighted to have him speak to us today, and he's very keen to have an interactive webinar. So what that means for you is, while you're currently all on mute, Richard encourages people to ask questions as he goes. And if you could please do that by raising your virtual hand on the Zoom screen, and we will attempt to make sure you can come off mute, or you can unmute yourself and ask your question. Thanks very much, everybody. I'd now like to pass over to Professor Richard Cookson. Thank you.
Thanks, Rachel, and thanks everyone for inviting me to this very interesting group. As Rachel says, it'd be great if we can make it interactive. There's nothing more boring than me rabbiting on. So shove things in the chat or put your hand up and just basically interrupt me. I'm very happy to be interrupted. So in my background, this is the flat that I'm staying in right now, not in England. I'm actually in Singapore, in the same time zone as you guys, which is nice. Yeah, so I'm just a visiting person here for a month. So I'm very excited to be looking at sort of equity issues in the Asian region. Yeah, so I'll just get on with it. And yeah, as I say, do interrupt me. Now I need to share my screen. I think that's it. I think that's directly into it. Can you all see that?
Perfect. Thanks, Richard.
Fab. All right. So I'm going to start talking. And as I say, do jump in. If you put your hand up and I haven't responded, just shout out, because I can't see on the screen I can't see the chat and I can't see any hands up. All right. So using distributional cost effectiveness analysis to help reduce health inequality. So this is all about the fact that policymakers at the moment see the world in white light, just in averages. They see average costs, average benefits, average quality. What we need to do is split out that average so that you see the distributions and who gains and who loses. Yes, by ethnic groups, you know, Marin or Marin in your case, but also by socioeconomic groups, whatever groups are of interest and importance in a particular society. And the idea is to show these distributions not just once every 10 years in a big fat report where we all moan and groan, oh dear, how sad, isn't this awful, but to show these distributions routinely in front of the faces of decision makers when they're actually making a decision, not in the appendix. of the report, but right there, front and square in front of their faces, so that they understand the equity implications of what they're doing, good or bad. So that's the point of this. And the agenda, I'll do a little bit of background and terminology, then get into what is DCA, and some key concepts. And I hope quite quickly to get into some examples of how this is done. We've got 2 examples that I'll show you, and then some further readings and so on. It would be nice. I don't know if we'll have time for this. I've got this tool, this web tool that we've developed in England. And if you want, you can shout out an example disease topic and I could show you a quick and dirty analysis just to prove that this can be done very quickly. But I'm not sure if we'll have time for that. Let's see. All right, so terminology. What is health inequality? Well, health variation is any difference in health which might not be unfair, just a fact. So there's variation in life expectancy by age, more likely to die if you're age 80 than if you're age 20. That might not be unfair. It might just be a fact of life. But health inequalities is when we think they're unfair. So, and typically it's when it's differences between more and less socially disadvantaged groups. And that's called health inequities by the World Health Organization, health disparities in the USA. And in England, we use the word health inequalities, and there's a confusion there because economists and mathematicians use the word inequality just to mean variation or difference. Whereas when I'm using the word inequality, I'm meaning an unfair difference. I mean an inequity. So just that's how I use the word. You can use it however you like. And the other thing to point out here is that equity can mean a whole bunch of other things, right? Not just health inequality, right? There's other unfair things in the universe. So severity of illness, that might be an unfair issue to think about. Rarity of the condition. There's all sorts of unfair, and there's all sorts of equity issues. If someone's in extreme distress, if there might be human rights issues, there's all sorts of equity issues in the world, which are not health inequality. So sometimes there are trade-offs between different kinds of equity issue, and we'll come on to that in a minute. Health inequality, back to health inequality, which is my topic here. Here's some, OECD data on health inequalities around the world. Where are you? Where's Australia? There's Australia. Not too bad, in the middle of that ranking. What's the red dot? The red dot is the female gap in life expectancy at age 25, and the blue dot is the male gap, 4 years and just below 8 years. But then when you adjust these things for morbidity, okay, if you look at the quality of life as well as the length of life, then these gaps all go up. They double on average. And this is just some OECD data. Obviously, you'll have different data. You'll have better data in your own country about these things. But there we are. There's a little international comparison. So it's an international problem. I just want to point out, look how small the Japan gap is, right? And I think it's fascinating that Asian countries tend to have smaller gaps. They have gaps, right? There's inequalities are pervasive, but the absolute value of these gaps tends to be smaller in some of these Asian countries. I don't understand why. I think it's a really interesting topic for further research. Okay, here's the gap in England, 12 QALY gap, right? We've adjusted for quality of life as well as length of life. Actually, this data is nearly 10 years old now. We need to update this. In fact, colleagues are updating it. But these gaps don't change much over time. If anything, it's probably grown a bit over the last 10 years. But there we are, 12 QALY gap between the richest fifth and poorest fifth, or actually this is deprivation, the most and least deprived fifths. And the idea of distributional cost effectiveness analysis is, what is the impact on that gap? It's a really simple question. Can you measure how that 12 QALY gap, so that's the individual level gap, if you multiply it up to the population level, you've got 135 million QALY gap between the top and bottom fifths of the English population. What is the effect of our decision on that gap? Really simple question. Okay, that's what DCA tries to evaluate. Okay, now the point of DCA is not just to describe the problem, right? We're not just describing those gaps and saying, oh dear, isn't it awful? Well, I mean, that's an important job. Describing things and pointing them out to decision makers is really important. But we need to do better than that. We need to measure the impact of decisions on changing inequalities. Okay, we need to move towards evaluating solutions, not just describing and despairing about problems. So, and this is the same, this is the same process that's been happening in other parts of health services research over the last decade. You start by measuring the costs and the burdens of illness, and then you move towards, evaluating the impacts of decisions on changing those costs and burdens. Exactly the same process is underway now with health inequality. We're shifting the focus of this field of study away from description and towards analysis of impacts. Okay, now I'm just going to move my Zoom bar out of the way of the title. Why quantify these impacts? Well, we want faster access to equity-enhancing interventions that disproportionately benefit more socially disadvantaged populations, as measured by deprivation or ethnicity. We want to address bias against conditions with higher prevalence in the more socially disadvantaged populations, which are often also underdiagnosed and poorly managed, these conditions. So it's a more rigorous, evidence-informed approach to reducing health inequalities, putting numbers on things. I hope people can still hear me. I'm always paranoid when I'm talking in these things that I'm just talking.
We can hear you, Richard.
You still hear me? Great, great. So as I say, do jump in anytime. Thank you so much, Rachel. Okay, now this is interesting. This is the trade-off, the equity trade-off that can sometimes happen with health inequality. So classically, you've got two different concepts of equity in the health technology assessment, trials type area. You've got health inequality that I've been talking about, and you've got severity of illness. Now, these things can go in different directions. So severity of illness tends to prioritize your emergency and acute hospital care for older people with late stage disease. Okay, you're severely ill when the disease is at the late stage. But health inequality is more about prioritizing primary preventive community care for children and working age adults with early stage disease or risk factors. So kind of not all the time, obviously these things can go in different directions and can benefit different population groups, but that's the sort of correlation, that's the thrust of it. So here's an example. Is it fairer to prioritize a new drug for late stage skin cancer or screening for maternal depression? Imagine they're equally effective, equally cost effective, okay? It's just the equity thing that differs. Now, in terms of severity, we're going to prioritize late stage skin cancer. Obviously, you've got a very short life expectancy and things like the end of life, the rule of rescue, all these things, kick in, all these ethical intuitions, help people who are suffering and dying right now, okay? But if you're interested in health inequality, you're going to give priority to the other one, to the maternal screening. Why? Well, because babies with depressed mothers can expect below average lifetime health and social status, and the skin cancer deaths are tending to be occurring above age 70 plus among people with above average lifetime health and social status. So if you want to reduce health inequality, you'll plump for maternal screening. If you want to address severity of illness concerns, you'll plump for late stage skin cancer. I'm not saying which is the right thing to do. I'm just saying that's the conflict. You've got a trade-off between two important concepts of equity, and you have to make your mind up which one is more important in this context. And ideally measure both and have some system for measuring both, which allows you to address that trade-off, which we can do with our equity weighting systems. You can do that. Okay, back to DCA. What is it? Well, it's analysis of equity in the distribution of costs and effects within the general population, as well as efficiency in terms of aggregate costs and effects. I emphasize general population. Equity is about the whole of the country, not just about differences within one particular disease group. Typically, we're talking about breakdowns between social advantage groups, such as deprivation, ethnicity. But you can also do two-group DCA when you just compare recipients, so you think of disadvantage in some way, versus non-recipients, everyone else. Very simple version. And there's other things you can do. You can do other kinds of distribution if you want to, data permitting. How can it help? Well, as I was saying, more transparent, more consistent, more evidence-informed approach to addressing equity, and to clarify and quantify the trade-offs that sometimes arise between cost effectiveness and equity, and between equity and equity, right? Different equity concerns might be important, and we have to understand that they're different and not kind of confuse them. If you understand that they're different concerns, then you can think about trade-offs. Okay. Strengths, quantitative. So what doesn't get measured gets marginalized. Comparative, you can compare equity impact between disease areas. This is actually very important. It's the same reason we use the QALY rather than disease-specific measures of outcome. We want to compare value for money between different areas. If you've got a general budget for healthcare, there's not just a budget for one specific kind of colon cancer, right? There's a budget for everything. And we have to make trade-offs between colon cancer treatments versus heart versus hip, whatever, right? So comparison is important, and that's why we use a general measure of health inequality, right? That's why we're talking about inequalities in lifetime QALYs, in quality-adjusted life expectancy at birth between the social groups. That allows us to compare between disease areas. We take a general population perspective, as I've said, and this approach allows us to integrate the analysis within the standard cost-effectiveness approach. It's not some separate thing in an appendix. It's right there, front and center, in the mainstream. Weaknesses or limitations, well, it's incomplete and imperfect, okay? You cannot capture every single equity concern in a single number, and there are data limitations, which are improving over time, and there's enough to get on with it now, but obviously there are limitations and uncertainties. It is resource intensive to set it up in a country, and there are various DCA building blocks that need to be set up. And in fact, Marianne Beaujolais is in the audience today. She's helping to set up one of the building blocks in Australia, which is the preference elicitation survey of what do the public think should be the equity weights and so on. So that's one of the building blocks. I'll come on to the others later. And then, doing a full DCA can be resource intensive. But as I'll show you later, a simple DCA is easier to do once the prevalence data are there, once the web tool is set up, then it's quite easy. It is conceptually challenging and hard to communicate at the moment because it's unfamiliar to people, as were QALYs and probabilistic sensitivity analysis and all sorts of other statistical concepts in the past 20, 30, 40, 50 years ago. Gradually, over time, these concepts become more familiar and easier to communicate. Now, the other limitation, of course, is all the advantages of DCA, right? If in fact it's comparative, quantitative, general population, and it goes with standard cost effectiveness analysis, I see these things as great advantages, right? But some people hate all of those things. In lobby groups, I don't like cost effectiveness. I don't like quantifying things. Equity is so subtle and ineffable, you can't possibly quantify it. So there you are. You can have these debates. Fine. So that's the limitations. Who could use this data? Well, I think loads of people, payers can use it for all sorts of decisions, okay? Basically any kind of decision, you can look at the equity impact and you can very quickly decide, okay, it's not relevant, right? It might not change a decision in this case, so let's not bother making a lot of effort. But sometimes it might be relevant and it's worth making some effort to quantify it properly. Industry could use this, obviously, if payers are actually willing to pay for equity, then industry will follow, right? Industry will start analyzing it and hopefully changing their behavior, right? And producing more equitable technologies. And finally, it can be used in the wide. I mean, in a sense, I see that the starting point here is health technology assessment. But in the end, I think these methods, these approaches could be used in much broader areas of health and social policy, where you have, even bigger money decisions, which are maybe even more important. But in this HTA space, this is where we've got the data and the statistics and the trials to actually, initiate some progress. Okay, I want to get on with it into some examples. So what I want to say here in this slide is just that when you're looking at technologies, new treatments, when you have a trial for something, it's relatively simple to do DCA. All you really need is data on the diagnosed prevalence of your disease, comparing, more and less disadvantaged groups. Basically, who benefits from this technology? That's what you need to know. And you can create a very simple prevalence inequality index, and that will give you a very reasonable first stab answer as to whether this is going to reduce or increase health inequality, and in a way, by how much as well. So let me just show you a very quick slide of I've mapped prevalence inequality versus the equity weight that you end up with once the sausage machine has been crunch through and look at that. It's not quite linear, but it's obviously it's not perfect, but it's a pretty strong correlation there. Basically, the more inequality and prevalence there is, the more likely you are to reduce health inequality and have some sort of equity benefit. Now, I don't want to go into the technical details of how I calculated this. It hasn't been published yet, but basically, all I want to say here is that that's the starting point. What is your prevalence inequality? That's the most important thing to find out. That's your starting point here. Okay. And if you want, you could stop there. You could just show decision makers, look, this is the prevalence inequality. That would be better than nothing, right? At the moment, they didn't even know that. They don't even know whether prevalence is higher or lower or by how much in different groups. So, I think it's time we actually at least show decision makers that amount of information and ideally give them the full Monty. And so then, this brings us on to triage DCA. Triage DCA is when you do the quick and simple analysis that I'll show you in a minute on the web tool, just to give an initial indication based on prevalence about whether you think this is going to increase or reduce health inequality. Then you can get better estimates, better data into the system to do simple DCA. And then finally, if you really think it's important, you can do full DCA, which is hard work. It's as hard as doing a standard DCA, right? So it requires under the bonnet modeling of things. But the simple DCA and the triage can be done just when you already have, you've got a basic cost effectiveness estimate, and then you build some simple further modeling on top of that. Maybe I don't need to talk about that. I'm just saying that, people think they know what the equity impact of an intervention is, but they're often wrong because you've got different steps in the staircase and things are complicated. So that's why you need to do a bit of analysis. Right, here are the building blocks I was mentioning. These are the things you need in your country. So you need to know what your equity relevant variables are. Are you talking about ethnic status? How are you measuring the groups? Are you talking about social disadvantage, socioeconomic? Well, how are you measuring those groups? So you need to decide what are your variables. In Australia, are you going to talk about 5 socioeconomic groups based on neighbourhood deprivation plus 2 ethnic groups, or are you going to have 2 times 5 groups? Are you going to have 10? Are you going to have 10 different subgroups? Within that. So obviously, within the ethnic groups, you've got your 5 social groups. So that there's that intersectionality stroke interaction question. So that's the first decision to make. Set up your classification system. Then you need your basic social distribution of baseline health. Kind of what is your starting point? How many QALYs are you losing in your worse off group? So drawing that picture. Then you need some estimate of the distribution of opportunity cost. This is very difficult. It's hard. You need to do fancy instrumental variable regressions and so on to get these numbers. We're doing that in the UK right now, and we're finding a very strange shape. I don't know if you can see me like this. It's an inverted U shape of that distribution we're finding, but we'd still assume it's flat at the moment because that's roughly right. But then you do sensitivity analysis around it. Anyway, that's the most difficult part at the moment. You just have to make an assumption and then do sensitivity. Then you need your equity weights. That's where you do a survey of the public or decision makers. Roughly, what is your benchmark degree of concern for health inequality? And then finally, you need to choose what is your what is your equity metric as a reference case. You need a general measure of inequality that you're going to use time and time again across different disease areas. It's no good having a slope index one day, then a Atkinson, then a threshold weight, and then I don't know. There's so many different equity indices out there. Colm. I'm trying to think of all this. There's lots of them. I'm trying to, there's some quite fancy ones as well. There's entropy measures, all sorts of fun things, or just gaps or ratios or God knows what. You just need to make a decision about one simple standard thing and stick with that, and then you can do your fancy indices, in the appendix. Okay, so that's that. Right, how am I doing for time? Oh dear, I've gone on too long. Forgive me. I don't know if. Shall we pause a little bit there, people? I'm sort of.
I think that's a good idea to pause and see if people have got questions for clarification or questions around sort of technical methods. If anyone would like to raise their virtual hand and come off mute.
Can I please have a quick question?
Please.
Yes.
Yeah. Thanks, Professor Coulson. It's a very interesting, maybe very silly question, but what's the most important factor? Sorry, the most important difference between TH and standard and full DCEA? Like, for example, if I just can do standard, is it still worth it? Or like in what situation people can say, oh, you have to do full DCEA?
You mean, sorry, standard cost effectiveness versus distributional?
No, I think in one slide, you say like a DCA, you can do standard, you can do full
Triage, simple, and full.
Oh, triage. Yes.
Yeah.
Oh,
Yeah.
yes. Good. Well, that's that. Yeah, absolutely. Ooh. Well, you start with triage. That's your start for I mean, I would say for any technology intervention decision, you would start by simply finding out what is the prevalence of this condition that I'm dealing with in the Maori population versus non-Maori. Forgive me if I'm not getting the right full description.
Aboriginal and Torres Strait Islanders.
Sorry, I'm getting the wrong country as
Australia.
well. Sorry. Aboriginal and Torres Strait Islanders versus non. Please tell us what the prevalence is of these conditions between that, and then, ideally tell us what the socioeconomic distribution is as well. So that's the first thing. And then you can do your triage very quickly. You can work out, roughly speaking, what would be the maximum plausible weight that you could have on this, and could it possibly shift a decision or not? Right? That's the first thing to do for anything. And once you've done that, if you see that actually it's not going to make any difference, right? Then don't bother. Then leave it. And mostly it won't make enough. Usually prevalence distributions are not that different, and so it's not worth doing further analysis. But if you see it's really important, and if the decision is really borderline, then you're going to go ahead to do the simple, a bit more further analysis. And then the question then is, do you need to? The difference between simple and full is nuanced. It's more a question of, basically, I would do simple every time unless there are complicated differences in what I call the staircase of inequality. So the first step is prevalence. The next step is uptake. Then there's the difference in the effect. Now, if you've got funny things going on, if prevalence is higher in the disadvantaged group, but uptake is lower, then you've got complications, and you might want to move to full DCA to model those complications properly. And the same with effect. Typically, the treatment effect on the treatment and on the treated is actually not very different between social groups. We're all human beings, similar biology. But sometimes, particularly for long-term conditions, diabetes or something, when you need to, maintain a diagnosis regime and a lifestyle change regime, then you do start to see differences in long-term treatment effect. And again, then you might want to do some modeling of that, which requires the full. So that's my answer. But start with triage.
Thank you very much. It's very clear.
Richard, I can see your hand.
Yeah, if I could just jump in a sec. Really interesting so far, and I've really enjoyed the kind of practical nature of how you actually begin thinking about this distributional CEA. I guess my question was around the distinction between like distributional CEA and more kind of equity weighted DEA, because distribution is only probably one part of equity. So I can think of a lot of equity concerns that people might have that are not really around distributional factors. So for instance, and this might be a silly example, people might want to prioritize people who are not responsible for their own ill health. So, people who go skiing and break a leg get relatively deprioritized because it's their own fault in some level. I'm assuming that your model is flexible enough to capture those kinds of nuances. But then the follow-up question is, if it is flexible enough to capture those nuances, does the approach to DCEA change as your elected officials switch from blue to red and back again?
Ooh, great questions. There's there's two ways of handling that. I mean, the specific issue of responsibility and choice that you raise, two ways of handling that. One is separately. What you might say, well, we've got an equity weight for the fact that, well, and so skiers, or let's say drug users, right? Imagine you have this view, oh dear, drug users are it's their own fault that they're taking drugs, right? If you take that view, then you might still, they're badly off, and it reduces health inequality to improve drug treatment, right? And that's your equity weight there. But you might then say, hang on, but we're not going to use the full fat equity weight for that, because we feel that drug use, it's sort of their own fault. So we're going to reduce the weight a bit. So you could either have a separate responsibility weight, right, if you wanted to, and de-weight it on that basis. Or smoking. Smoking is a classic example. Smoking cessation services. A lot of people say, well, yes, it reduces health inequality, but smoking is your own fault. Tough. So you basically you either have a separate system of weights which conflict, or you could build into the health inequality equity weight a sort of responsibility element. You can create social welfare functions which have that fine. So those are the two ways you could do that. Both of which are numerical, by the way. And the same with severity weights. We've got a system of severity weighting at NICE at any rate, and in the Netherlands and various other countries. So we've got a system of severity weights up and running. We can have a system of health inequality weights up and running, and then you just put the two things together. That tells you what the trade-off is. And the same would apply if you wanted to have responsibility weights. Now, as you well know, responsibility is a very tricky one, and the problem is people have different opinions about how much choice and responsibility there really is, right? It's very deep questions of free will. So it turns out to be two. When we do surveys of this of the public, once they understand how complicated it is, they tend to be less keen on the responsibility thing. If you did a citizens' jury about responsibility, I bet. Well, we've sort of done this actually in the past. People's views start off, yeah, smoking tough, and then when they realize how complicated it is, and actually the reason you smoke might be because of all the difficult situations in your life and Anyway. Sorry, what was the second? Oh, the second part is, does it switch as the policymakers switch? That's a really tricky constitutional question, and I don't know. I mean, probably, why not? I mean, we're supposed to be serving the decision maker, and if the decision maker changes color and wants to set a different set of equity weights, that's their prerogative. So I think you could shift. In practice, that doesn't happen, does it? In practice, I've never seen any HTA agency actually change its quali weights or its equity stance for purely party political changes. So funny enough, institutional values are quite stable, which is quite interesting. But in principle, they could be changed.
Right. Thanks, Richard. Anja.
Thank you. Thank you, Richard. Thank you very much. I'm Tingjia Wang. I'm a research fellow at Griffith University. I'm really keen to learn techniques about DCEA. My apologize if my question is a bit harsh, but I really want to know your opinions on that. A recently released Australian report named as HTA, let me have a look, HTA Policy and Methods Review, and they concluded that, quote, equity-informed economic evaluation should not be used as an algorithm for decision making. And they also highlighted that, quote, the standardized incorporation of distributional cost effectiveness or other health outcome disaggregations may therefore serve to undermine the promotion of equity in established HTA processes. So what do you think about that?
Right. Well,
sorry about that.
I mean, people have all sorts of opinions and all sorts of reasons for their opinions. And, all I can do is argue on the basis of reason and evidence. So I'll try and do that. So if you're interested in reason and evidence, then you probably want to have some sort of reason and evidence used in your decision making, right? So if you're interested in equity, you wouldn't just want equity to be taken into account by the WISE committee and not tell anyone why they're doing things. You know, one day in their wisdom, the committee chooses this thing, and the next day they choose that thing, and they say, oh, it's because of equity. It's all because of equity. We care so much. You'd want to say, well, hang on, can you please explain why you're making that choice, right? So that we can check your reasoning and your evidence. So that's the idea. And the point of DCA is to try to get a little bit of evidence and a little bit of reasoning into the decision-making, so that the public and other people can check what the WISE committee has done. What else can I say? And the other thing to say is I think there's a lot of confusion and sort of, yeah, people say, oh, it's too difficult, it's too complicated. Oh, dear me, I don't understand what an Atkinson parameter is. And ooh, do you know what I mean? Well, that's, you know, a little bit pathetic. I mean, you know, research it properly, investigate it. What data do you actually need? In fact, if you think about it and talk to me about it, you realize, in fact, it's not that difficult. You just need prevalence data. And your point is, what's the point? Is something, I think, is better than nothing. You don't have to move to the full high-fat DCA, which is very complicated. You can do compromises. You can do a small, simple triage version of DCA to start with, and then gradually build on that or not. So that's my response to that committee's report. They didn't talk to me. They probably read something and didn't understand it and got all upset about it. What I would say to that committee is talk to the experts, use your noddle, and think about the real data implications here. Don't just be ideologically biased. Oh, we don't like weights, we don't like quantification. You know, that attitude doesn't really get you anywhere. There you go.
Thank you. Thank you very much.
Great, thank you. Richard, I know you've got a few more slides to go through, and there are no one's got their hands up at the moment. So, do you want to go back to your slide?
Shall I keep going? Yeah, why not?
Sure. We've got about 20 minutes left in the session, so maybe roughly 10 minutes of presentation, then give people time at the end to ask any burning questions, something along those lines. But
fantastic. Yeah.
See how we go.
Let's do it that way. Fine.
Yeah. Thanks.
Yeah, brilliant. And one more thing to say, now that I'm on a rant, the other thing to say is, if decision makers are serious about equity, they should be willing to pay for it. It's all very well coming out with statements about how you love equity and you care so much. But if you're not willing to put money where your mouth is, then it's all just talk. So, you know, one of the aims of this work is to get some numbers there and to, you know, encourage decision makers to put money where their mouth is on equity, rather than just talking about it and, you know, waving their hands. Right, there you go. End of rant. Okay, so back to the slides. Right, key concepts. Okay, I'm hoping you can see that now. So here's the staircase. Yes, this is really important. So there is various steps on the staircase towards your health inequality impact. And the first and most important step is the bottom step there, which is the prevalence of this disease among your more or less socially disadvantaged groups. That's the eligible population. Basically, who is going to benefit from this intervention? That's the most fundamental step. And it's the only step that's really important, typically for new technologies, because the other steps are kind of fixed. You can't really change them by the decision. Second step is uptake, who's going to actually use it. Then there's effectiveness, and finally there's the opportunity cost. Now, for public health things like smoking cessation or, you know, exercise or whatever it is, then, you know, uptake is absolutely crucial, or you know, screening, classically screening, you know, lung screening, whatever. And then, you know, you need to look at the interaction between the two, and things get more complicated. But for new technologies, it's all about the eligible population. Because basically, if you've got some, you know, late stage cancer, you know, you're going to be in that hospital, you're going to be diagnosed. You know, you will get the treatment if it's available. You won't if it's not. You know, there isn't really a different uptake thing there. You know, once you're diagnosed in the system, you know, you're going to get access to it. So, you know, at least in a society like Australia, where, you know, reasonable universal coverage of healthcare, you know, in places like, you know, United States and so on, where you don't have universal coverage, sure, the money really matters, and rich people are more likely to get access to something. But in countries with universal coverage, yeah, the prevalence distribution is what really matters at this first stage. Okay, And then, what a lot of people focus on wrongly in this field is the randomized controlled trial of, treatment effect on the treated. There's all this stuff about heterogeneous treatment effects and, oh dear, you don't have the power to do it and blah, blah, blah. And very clever econometricians come up with more and more fancy ways of looking at conditional average treatment effects. Yeah, it's all very well, but we're not, the difference in effect, treatment effect on the treated for a new drug is not that different between social subgroups. So in a way, you can spend a lot of time faffing about with that, pooling data and all that. And actually, the real big differences are at this stage, the eligible population stage. So that's what you should spend your time and effort on, not at this stage, in my humble opinion. Sorry, as you're seeing, I've got various humble opinions about things. It's because I've been in this field 20 years and I've seen things go round and round. Okay. Another key concept is this plane, the equity efficiency trade-off plane or impact plane. So, if you're cost effective and you're reducing health inequality, you're in that nice green win-win quadrant. If you're neither, you're in the red. And sometimes you've got trade-offs. You might be really cost effective, but you might increase health inequality. This is your classic public health preventive intervention where more advantaged people take it up. So it's really cost effective, but it tends to increase health inequality. Can we redesign that public health intervention to reach more disadvantaged people and to benefit them more? Or you've got the other thing, this is sort of a new drugs type thing, really expensive, not cost effective, but it really benefits disadvantaged groups. So maybe we're going to pay a bit more. Maybe we're willing to pay a bit more for that. Money where our mouth is. And there's where the equity weights come in. Okay, so that's the plane. And then we've talked about the equity weights. How much weight are you going to give? And possibly how much less weight will you give to things that are not cost effective, right? That's the classic opportunity cost thing that us health economists go on about. If you're going to give a bonus to some technologies, maybe you're going to deprioritize other technologies, either implicitly or explicitly. And then the way we do weights in this field is we have a thing called a health inequality aversion parameter, typically goes from 0 to 11 or so, and that will set your weights on the different groups, and then you can vary that parameter. And there's a whole bunch of debate about how you should formulate this and so on. I take a very simple approach, just use a simple, it's called an Atkinson inequality aversion parameter. And then the nice thing is you just vary this parameter and it allows you to change the weights on the different groups and do some sensitivity. If you go for more fancy things, you end up with 2 parameters and it gets all a bit complicated. But, there's a debate about that and that's fine.
Richard, I wondered, I know we've had quite a few questions about, where you get the equity weights from. And so I wondered whether you could point people to some resources around the simple method that you just mentioned then using, was it Atkinson's
Yes.
weights and just the process of using those, or if you were to survey decision makers, what you would do in order to obtain those weights.
Yeah, so the kind of survey we do, the simple method is a bit like this.
Yeah.
So, very hypothetical question, program A or program B. Program A is the one that benefits the more advantaged group, and program B benefits the more disadvantaged group. But as you can see in program B, the total gain is less than in program A. That's where you get your trade-off. And so you start with a question like this, which would you choose? And then gradually, if people say, well, I'll choose program B because that reduces health inequality, then you start making program B less and less efficient, right? And benefiting the poorest group or the most disadvantaged group less and less until you reach a sort of indifference point, a trade-off point. And that trade-off point is what effectively gives you your, how much you care about health inequality, reducing health inequality versus improving health. And then you do a bit of fancy maths and you get a number out. I haven't got the maths and stuff in front of me here, but basically you end up with this parameter from 0 to 11 roughly. And as you change that parameter, it gives you a different set of weights for your 5 or 10 or however many there are social groups. And the weight is based on the level. So an Atkinson function is a level dependent equity weight. It all depends on the level of your baseline health inequality, baseline health. So in this case, we've got the richest group is what, 74 QALYs life expectancy, healthy adjusted life expectancy, and the poorer group is 62. So the weight they get will be sort of proportional to that. baseline health. And the nice thing about that is it means that, you know, if you've got an indigenous group that's really badly off, right, has much worse health than the other group, then, you know, they're going to get a much higher weight because it's proportional to the baseline. And that seems the fair way of doing it. Whereas if you've only got a small gap between, you know, the richest and the next richest group, if that gap is a bit smaller, then you'll get a smaller weight. So, yeah, it kind of makes sense how the level dependent weights work.
Right, thank you.
Resources, I've got some readings here. Where are the readings? So the Robson paper is the starting point for this. Robson et al. 2017. But Marianne in the audience is going to be very soon producing Australian estimates. So there will be some numbers. Before long, there will be some numbers for the Australian context. Is that okay?
Yes, thank you. That's good.
Brilliant. So, so back to where I was. So I won't talk about, so there's steps in doing the analysis. You start with the baseline distribution, then you estimate the benefits and the costs, you put them together, and then you produce your distribution of net health benefits, and then you do various, you know, indices, weights, all that. So let me just show you, this is a sensitivity around opportunity cost. You know, that's fairly straightforward. Let me just show you some numbers here. So here's, you know, a treatment for sickle cell disease. This is not one of the new, you know, fancy, expensive, but very effective gene therapy things for sickle cell, which are coming out. This is one of the earlier generation. Basically, you know, it's the same old story. It wasn't cost effective, but it did reduce health inequality. And the why does it introduce health inequality? Well, but this is the prevalence distribution of sickle cell in the UK, in England, by deprivation. This is area neighbourhood deprivation. So you can see that the most deprived, you know, the most deprived 40% of the English population, much more likely to benefit from this because, you know, Black and other ethnic groups that are more likely to get sickle cell for interesting historical reasons to do with malaria prevalence, where their ancestors were born. But anyway, the prevalence is really extremely concentrated on more disadvantaged groups, and so therefore, of course, this technology is going to reduce health inequality. And so when you work through the numbers, the health benefits there, we're just assuming they're in proportion to the prevalence, very simple assumption, a reasonable assumption in this case. The opportunity costs are there, they're flat, we're assuming a flat distribution of opportunity costs. And when you add those two things together, you get this kind of distribution of net health benefits. The most disadvantaged groups are gaining, the least disadvantaged groups are losing because of the opportunity costs. But overall, you're going to be reducing health inequality. And that's your triage DC, that's your quick and dirty analysis. Question mark, could this change your decision? Well, then here's the equity impact plane here, right? It's in that classic bottom right quadrant. You know, you're not cost effective, but you are reducing health inequality. Could it reduce health inequality? Well, here's the sort of ballpark size of the impact, the net health inequality benefit, that 246 QALYs, that's your reduction. You remember I showed you the 35 million QALY gap baseline? Well, that's your reduction in that huge gap. And the question is, could it modify a decision? Well, here's the answer. If, you know, we're assuming various things here, but if the cost effectiveness ratio is £40,000 per QALY, which is slightly too expensive usually for the standard UK decisions, because the normal threshold is 30,000. If you shove the maximum plausible equity weights in here using an Atkinson of 10, then you get a reduction of 30% in your ISA, or an ISA weight, equivalent ISA weight, the way the relativities work, so it's 1.42 is the ISA weight you'd apply to that. So basically, you would need an inequality aversion parameter of 8 or more to say, yes, we will fund this. So that's your analysis. And the answer is yes, it could possibly modify a decision. So it's worth doing a bit more analysis. So that's your triage approach. And I've got a little web tool which can do all this, you know, at the click of a button once you shove in these parameters. So that's the crizanlizumab example. Let me give a quick, more complicated example. This is lung health checks. It's more complicated because it's public health and uptake really matters. You really, you know, whether you turn up for your lung health check is a crucial feature of this. So lung health checks, age 55 to 75. Here's the current distribution of at risk, people at risk of lung cancer. Current and former smokers. Now, why is this less in the more deprived? I'm getting very confused here. I think what we've done here in this picture is we've looked at uptake. We've made assumptions about both prevalence and uptake. That's why you've got a lower uptake in the poorest groups. So what happens is this is the combination of two variables. You're more likely to be at risk of lung cancer, of course, more likely to smoke in the poorer groups, but you're less likely to turn up for your lung health check according to the standard screening approach. So that's why you end up with this pattern. And that's why you end up with this kind of situation where the net health benefit is actually higher in the more advantaged groups. So you're actually increasing health inequality by doing lung health checks. Paradoxically, you're increasing it because of that uptake problem. So it's in this quadrant. And would it change the decision? Probably not, because it's really cost effective. So you probably do it anyway, at least according to these numbers. I should say that these are very rough and ready numbers, and there is debate about the cost effectiveness of this. But if these numbers are true, it probably wouldn't modify a decision. But nevertheless, you might want to think about ways of redesigning the program to increase uptake in more disadvantaged areas. And the classic way of increasing uptake is to shove lung screening vans in supermarket car parks. That's the way to get uptake up in disadvantaged areas. And they've done a load of pilots around the UK, maybe they've done it in Australia as well. And basically that it works really well. That then increases uptake and shifts you towards the win-win quadrant. So this is a case of wanting to redesign delivery rather than saying no to the program. So that's that. And we've talked about trade-offs, and I think I want to stop there. I think time is running out. I want to stop there.
I think that's, I think that's a great idea with just a few minutes left.
Yeah.
So we've got time for a couple of questions. If people could please raise their hands, and you can bring yourself off mute. I don't know, Marianne, if you wanted to ask. Yes. Excellent.
Great.
Just on time. Thank you very much, Richard. So yes, we did quantify the Atkinson and Cohn parameter for Australia across 3 equity relevant dimensions. But I was wondering, I didn't really explore the online tool, but I was wondering, is it flexible enough that we can use it as well if we change some parameters, or is it based on UK data?
You can use it. There's a version of it that I've created in Excel, which you could tailor it to Australia. I'm happy to share that with you by putting in your own baseline estimates. And then you could put, but you would have to put in all the data, particularly the prevalence data. What we've got under our tool is a whole bunch of prevalence numbers for the whole UK population, English population, based on hospital data. That's in a way the difficult bit. But as long as you put in your own prevalence numbers and own assumptions about baseline health, then yeah, I mean, sure, you can tailor the tool. What I'm hoping is that someone in Australia is going to get hold of the prevalence data, and I'm talking to people about that.
Yeah, thank you.
Thank you, Richard. We have another question, but sorry, I can't quite see who it is. So who's got the hand up? Could you ask your question, please?
Hi, so sorry, my name is Nhung Nghiams. I'm just joining you from New Zealand. I joined on my laptop, but unfortunately it just doesn't work, so I joined on my phone. So I just have, thanks Richard for the very nice presentation. I just have a quick question about how to communicate the result, health inequality result to policymaker, because we have done a lot of work for health inequality in New Zealand, like for Maori and non-Maori that you just mentioned.
Yeah.
Like we did about tobacco endgames and tobacco tax. And last year we got like the parliament passed our first tobacco endgames in New Zealand. But unfortunately, the new government come in and they just doesn't approve that legislation. So I was wondering, what is your advice on communicate the result to the policy makers and like make it into a good policy? Thank you.
Yeah, well, It's difficult, but I've given my little rant already. I mean, I think my rant is something like, if you're serious, if you do care about these things, then you need to put money where your mouth is, and you need to develop quantitative evidence-based systems for thinking about these things in a consistent way, rather than just leaving it as something that we'll think about maybe, because then it's kind of kicking it into the long grass, isn't it? We'll think about it a bit, maybe sometimes. I mean, that's no good.
Thank
So
you,
I don't know.
Richard.
So sorry, not very helpful, but keep plugging away. I do think that governments do actually want to consider these issues, and I think that once they understand actually this can be done and can be helpful, that's the point. This actually can be very useful for someone who's interested in equity. It's not scary. I mean, it's the same as the QALY. People don't like the QALY; they're scared of it. Actually, it can be quite helpful for making decisions. If you understand what it does and why, you'd be less scared of it. It's a bit like prejudice in general, but I think people are prejudiced against DCA. There you are. They need to become familiar with it, and it's not so scary and bad.
Thanks, Richard.
Thank you. Thanks for your questions. And you might wish to contact Richard via his email if you have other questions, because we're out of time for this webinar. But on behalf of the team at ACTA, Vivian and Amanda, Richard Norman and myself, we'd like to thank you very much, Richard Cookson, for your terrific topic. It's engaged a lot of Australian researchers, that's for sure. And thank you very much for the resources. My understanding is that ACTA, who have been recording this webinar, will also place the resources online, and maybe some highlights from your content if you're able to share any of that. One of the points in closing I'd like to make is that ACTA has a series of awards, and there's one award specifically for health economists, and this was a new award last year, and we're very pleased to let people know that the awards themselves will be announced in May, and the award for health economics is called the ACTA Heat Excellence in Trial-Based Health Economics. So it must represent a publication that was in the calendar year 2023 and is a really good example of a economics research alongside a randomized trial. So the deadline for submission for that award is Friday the 29th of March. Just to let everybody know, please put it in your diaries. So thank you very much on behalf of the team, and we will have our next webinar towards the end of April, as I mentioned, on quality of life, and look forward to seeing you all then. Thank you very much, Richard.
Thanks so much. Great fun.
Thank you.
I hope that in a couple of years' time, that award will be won by someone doing a DCA based on a trial. Why not?
Yes, why not?
Sounds great.